Hey guys, this is Dr. Hub. Today we'll look at the blood transfusion reactions. So to begin with, first we have the reaction, that is the anaphylactic transfusion reaction. So this occurs from seconds to minutes. So what will be the mechanism of this? The mechanism is that it is common in IgA deficient recipients. It is common in the IgA deficient recipients. And how is the presentation? So here there is a presence of shock. There will be respiratory distress, as well as there is presence of the angioedema. Next, let's look at how to manage this situation. So the management here, it is going to be by, there is to stop the transfusion immediately. So you stop the transfusion. This will be done immediately. And you give epinephrine. Then comes the prevention. So you do prevention. So prevention is using a IgA deficient. So you give a IgA deficient plasma. Using IgA deficient plasma and wash cellular blood components and washed cellular blood components. Then comes we look at the allergic. The next reaction is the allergic or the urticarial transfusion reaction. So allergic urticarial transfusion reaction. So this will occur within 2 to 3 hours. Next, we look at the mechanism. So mechanism, if you see, the recipient has IgE and this is against the donor components. This is against donor components and causing the mast cell activation. Causing mast cell activation. So how does it present with? The presentation is by urticaria, as well as there is flushing and the pruritus. Then how do you manage this situation? The management will be by stop the transfusion, and this will be immediately. Next will be the aggressive management. The aggressive management with the IV fluids. This is all for the allergic and the urticarial transfusion reactions. Next, we have the febrile non-hemolytic transfusion reaction. There is a febrile non-hemolytic transfusion reaction. So this is within 6 hours. This is going to be within 6 hours, and it is more common complication of the blood transfusion. So more common complication of the blood transfusion as a febrile non-hemolytic transfusion reaction. So how is the mechanism? The mechanism is that there is antibodies are against the donor WBC, as well as the HLA antigens. So this is nothing but the sensitization. Then comes the cytokine accumulation during the blood storage. The cytokine accumulation, this is during blood storage. Then comes, it is more common in multi-pally it is more common in terms of the multipally transfused patients and the multiparous woman. Multiparous woman. Next comes the presentation. So the presentation is going to be the fever. There is fever as well as chills, and sometimes there is also the mild dyspnea. Then we move on to the management. How do you manage this? So the management here is by administration of antihistamines and also the antipyretics. Antihistamines and the antipyretics. Then there is also transfusion. It can be stopped. The transfusion can be stopped. And when is it stopped? If the symptoms are severe, then the transfusion can be stopped. So how do you prevent this? The prevention is by the leuko-reduced products. Use of the leuko-reduced products. Next, we will look at the TRALI. So in short, it is known as the TRALI. So TRALI means there is a transfusion related acute lung injury. So transfusion related acute lung injury. So this occurs by 1 to 6 hours. And after this, what is the mechanism? Mechanism is that there is a anti-HLA. There is anti-HLA type 2. So anti-HLA type 2 antibodies. So this is present in the donor plasma. This is present in the donor plasma, and they bind to the recipient. They bind to the recipient, and there is also the WBC, and it increases the capillary permeability. Capillary permeability. Then we will look at the presentation. The presentation of TRALI is that there can be hypoxia. There's hypoxia. Then there's non-cardiogenic pulmonary edema. There is hypoxia, non-cardiogenic pulmonary edema. And looking at the CXR, there is a bilateral interstitial infiltrates. Now, let's look at how to manage this. So the management is by stop the transfusion immediately. So you stop the transfusion immediately, as well as you administer the supportive care. Supportive care can be given. Next, we look at the acute hemolytic transfusion reaction. There is acute hemolytic transfusion reaction. So as per the acute hemolytic transfusion reaction, this is done during transfusion. During the transfusion, and this is within the 24 hours. So what is the mechanism of this acute hemolytic transfusion reaction? There is a ABO, and this is incompatibility. There is a ABO incompatibility. There is a type 2 hypersensitivity, and there is a pre-existing high affinity. This is the IgM antibodies, and what happens is these pre-existing high affinity IgM antibodies, they rapidly induce the complement. They induce a complement mediated lysis. They induce a complement mediated lysis, as well as the intravascular hemolysis. Intravascular hemolysis and the hemoglobinuria. Now let's look at how is the presentation of the acute hemolytic transfusion reaction. So there can be presence of fever, there is chills, there is also the flank and the back pain. So what are the other features? It also includes the sense of, this is all an acute hemolytic transfusion reaction, the sense of impending doom, and there is also the hemoglobinuria, there is DIC as well as the renal failure. Next, there is also the Coombs test. The Coombs test, if you see, it is positive and there is pink plasma. So how do you treat this? The treatment is by, it stops the transfusion immediately. Stop transfusion immediately, and there's an aggressive, you do aggressive management, and this is going to be with the IV fluids. So aggressive management with the IV fluids. Lastly, we look at the delayed hemolytic transfusion reaction. So in the delayed hemolytic transfusion reaction, so this delayed will occur after 24 hours. It occurs after 24 hours and it is usually 2 weeks. So what are the features here? So the mechanism is that the recipients have prior exposure to RBC. So recipients have prior exposure to the RBC antigens, and after the transfusion, so after transfusion there is a anamnestic response. And this results in the antibody production. So typically that is caused by the IgG antibodies. So it is caused by the IgG antibodies, and this is to a foreign protein antigens. And associated with the lab features of hemolysis. There's lab features of the hemolysis. So what is the presentation of this delayed hemolytic transfusion? There can be mild fever. There is also presence of the hemolytic anemia. It can be Coombs test positive. The Coombs test is positive, as well as there is screening. So screening for the new antibody positive. Then let's look at the management. Management will be the supportive care as well as the additional transfusions. This is if required. Next, we'll move ahead with the non-immune mediated. So, the non-immune mediated transfusion reaction. So under this, what do we have? We have TACO. So TACO stands for the transfusion associated circulatory overload. Then comes the hypothermia. The hypothermia and the electrolyte abnormality. So if you look at the electron abnormality, what does it include? This includes the hyperkalemia. So electrolyte abnormality includes the hyperkalemia as well as the hypocalcemia. Next, we also have the iron overload and the transient. There's transient hypotension. There's a iron overload, transient hypotension. Next comes the immunomodulation. There's immunomodulation as well as the blood-borne diseases, blood-borne infections.